I'd now like to introduce Deputy Secretary of the Department of Health and Human Services, Eric Hargan. One of his department's top priorities is to reform, strengthen, and modernize the nation's healthcare system. How does that goal intersect with the changes taking place across the healthcare ecosystem, and what is the role that regulators can play? Let's find out. Welcome, Deputy Secretary Hargan, and the floor is yours, Alexa.
You're pretty happy to be here talking about this topic and maybe not another one at the border, aren't
bet.
you? Yes.
You bet.
Yes.
Absolutely.
Good morning.
Good morning.
We've been listening to the senator and the congressman talking about this trend that we're seeing in the private sector, and you're very aware of it. You were in the private sector. You have a wealth of experience in government outside of it. So let me start where I started with them. From HHS's perspective, do you think that the trends that we're seeing in terms of mergers, acquisitions, collaborations, trying to find abilities to scale up,
Sure.
are they being prompted sort of by government, or innovations that we've seen by government, or in spite of it?
Sure. I think that we're kind of looking at a mixed bag here. Sometimes we have, obviously sometimes the drive to kind of consolidate care can drive up costs in the system, and sometimes inadvertently the regulatory or the reimbursement system really supercharges that drive towards consolidation. Things that government might do, sometimes inadvertently, will lead to consolidation that may or may not drive up costs. In many cases, we want to be in a situation where we're kind of level about the issue of whether we should have consolidation or not in an industry. That's talking purely from kind of a merger and acquisition point of view. But the drive to coordinate, I think, is separate from that. The issue of whether or not who owns it is different from the question of whether or not they should be coordinated. Because coordination can have a lot of benefits for care, regardless of who is sort of owning the assets within the system and along the chain. So we want to be able to enable helpful coordination among different players in healthcare to make sure that patients get the best care, that you kind of have end-to-end treatment where you don't lose the patient somewhere in the system, and be able to enable them to get the best kind of care from all the different actors in the healthcare sort of chain, the continuum of care. But we want to make sure that nothing we're doing is inadvertently driving either harmful consolidation or disaggregation from that point of view.
Before we get to the tools that HHS is using, from your perspective, and considering the sweep of jobs and career entries that you've had in healthcare, what concerns you about this trend, if anything?
Well, I think the concern here is that we end up with a system that is not responsive enough to patient needs, that we sort of inadvertently drive ourselves to a situation where we have sort of the wrong level of coordination. There's a way in which you can sort of capture patients within a system that might not create the best model of care. And we don't want to inadvertently sort of lead ourselves into that. So I think that's one of the things that we want to enable coordination, and that's part of what I was trying to do with the regulatory sprint to coordinated care. I think that we've seen over time some of the laws that we've put in place that were attempted to kind of get at some of the problems of the prior versions of our healthcare system are now working kind of at cross purposes with where we're trying to go.
Talk a little bit more about the regulatory efforts that HHS, you're spearheading. This is an area that you're intimately familiar with from your past experience. And in the private sector.
Right.
Talk about what you're trying to do in the time frame.
Sure. So this is the regulatory sprint to coordinated care, and those words are kind of chosen carefully. One is regulatory, so we're going to try to do things that we can do within HHS from a regulatory point of view. It's a sprint because the system we've got could need years of analysis before we get to understanding how to make it perfect. So we're trying to get kind of the low-hanging fruit. We're trying to do this in a sprint. That is, try to identify things that we can do quickly to enable coordinated care. And then we're focusing on 4 areas that have where we've heard a lot of feedback or experience that there have been problems in this area. The Stark Law, the Anti-Kickback Statute, HIPAA, and 42 CFR Part 2, which is a provision that a lot of people in the opioids and substance use disorder area think is harming their ability to coordinate their care. So each of those laws was set up for a good reason, and they have to stay in place in many cases. It's just that sometimes sort of well-meaning adjustments over time have resulted in kind of an incrustation of regulations and guidances over time that we now think we could kind of usefully kind of get rid of some of those or enable better coordination between the systems of laws. We got 4 different agencies that each have places. They each have different regulatory capacities in here. So whether it's CMS with Stark, whether it's the Inspector General with the anti-kickback statute and the safe harbors there, whether it's SAMHSA with 42 CFR Part 2 or the Office for Civil Rights for HIPAA, you have 4 different agencies that are each kind of carrying out their own law. And of course, naturally, over time, those 4 agencies are kind of get out of whack with each other. They kind of get out of sync. And so we're going to try to make sure that we preserve the patient rights and the protections that are in those laws and the protections for the system overall, while enabling sort of a lowering overall of burden where it's unnecessary. We have duplication, unnecessary regulation that, you know, one of the agencies covers something, the other one does too, but a slightly different way, which leads to confusion out there in the industry. Do I follow this agency or that agency? They're both speaking to the exact same issue. Which one should I follow? Well, the agencies can decide between themselves. Maybe I should handle this one, and you handle that one. I'll handle this one, you handle that one. So that coordination is something that we can do usefully at kind of the departmental level. We can kind of sponsor that, bring them together, along with listening sessions for stakeholders, whether it's patient groups, industry stakeholders, to kind of get them in a room and let us know where they see the problems as well.
Just to follow up, there is no legislative effort that you're making in those 4 categories, those 4 triage elements that you were talking about. You want to try to do this through regulatory, administrative efforts.
That's my focus. I mean, there are obviously, there have been, I mean, Congressman Stark, who started the Stark Law, has kind of criticized his own law. So his self-named law, he himself has come out to say that there are issues with it. But that level of sort of the legislative attention there may be going on otherwise, but that's not really the focus that I'm bringing to this. I mean, that's my background as kind of a regulatory and corporate lawyer. This is a place where I think I can usefully kind of bring my experience to bear most usefully and try to create, from my vantage point, coordination among the agencies so that they can, you know, kind of achieve the best balance between what they're required to do and should be doing under law, and then the kind of removing the, as I say, the incrustations, the barnacles that develop on a regulatory system over time, kind of inevitably.
And speed means next year?
Yeah, I mean, next year, later this year.
Later this year?
We're working pretty hard. I mean, when I came in and sort of brought the staff, the HHS staff together on this issue internally, I found a tremendous outpouring of support for this, that there were a lot of people who had been frustrated by this internally, and were really looking for an opportunity, a platform to do this work. So that means there was an awful lot that had already been thought through within the agencies in many cases on these very same issues. And so they just really needed kind of a platform, a springboard to kind of move this forward. So I think that's where, I mean, that was, I mean, tremendously heartening, because, you know, it's good to see that a lot of the people internally who are experts in this area had seen the same issues that I had seen from outside with this, and so they're really sprung into action. So, I mean, we're making sure that we kind of reach out to the public to get their perspectives on this as well, because we're not trying to sort of develop a government-devised solution to a government-devised problem, right? So we're trying to make sure we get as much in reach from the public broadly, and then move forward after we've got that.
I know we were going to have some questions in the audience. In the minutes that we have, is there anybody here who would like to talk to the deputy with questions? We have a gentleman right here. Hold on, wait for the microphone.
Thank you. Bill Finnerfrock with Capital Associates. Recently, the Secretary rejected about 12 or 13 alternative payment models that were submitted by various physician organizations, and that's had a chilling effect on the efforts for innovation and things that other specialties were considering. Do you have any advice, or is there anything to suggest that the department will seriously consider alternative payment models that are going to be developed by groups outside of CMS or HHS as we move forward?
Yeah. So, I mean, if you're talking there about sort of the PTAC situation, yeah. I mean, I think that we are still ongoing in discussions with PTAC and other groups about developing alternative payment models. So we're not kind of shelving at all the idea that, and in fact, I think we're welcoming the development of models that we can put in place to implement that are going to be useful going forward. I mean, we know that that's even sort of one of the pillars that we're following, that we want to develop innovative payment models in CMS, whether inside or outside. So I think we're we've definitely reached out to the physician community, among others, to help kind of bring models in. And I know that we're going to be looking at not just the exact models that they have, which we're continuing to do as they're developed, but also kind of taking the ideas and using the ideas that we're hearing from them internally to kind of inform also models that are being looked at inside the department. So yeah, we're not in any way kind of shutting that process down.
Who else do we have? Oh, we have another hand down here. This gentleman right here.
Good morning. Thank you for being here. My name is Han Pak. I'm the Chief Medical Officer for 3M Health Information System. I'm a practicing physician, and so I hear a lot from my colleagues about the burden of reporting and all the issues, and yeah, we want to do the right thing. And so philosophically, I guess I had a question for you regarding these process measures versus outcome measures, especially as we think about coordinating the care. We all recognize individually as a physician, we can't be the one stop that we take care of all the needs of our patients, and it takes a community. Could you talk a little bit about your approach or your department's approach regarding process versus outcomes, especially as it regards to measuring performance?
Sure.
This is a small topic.
Sure, yeah. So we've got the rest of the day and tomorrow
Yeah,
set aside
exactly.
for everyone.
PhD,
So, yeah, everybody. So obviously the drive to value-based care, focusing on outcomes is got to be central to that, because we want to move to a system where we're sort of oriented on that as opposed to process-based. I mean, the movement from, broadly speaking, fee-for-service to value-based care is a movement from kind of being oriented around looking at one particular service by service, process by process, and moving to one that's oriented more on overall outcomes. Now, how you measure those outcomes is obviously a matter of great moment, right? That sort of sets the ground for how we're moving on value-based care. So, we have to look at a lot of things in there, including sort of price and quality transparency, because you have to be able to understand what's going on in the system, both from the point of view of where you're getting the prices and the costs in the system, as well as the quality side on outcomes, so that we understand not just that we're paying for quality care, but what we're getting. Like, in other words, what are we actually paying for in that system, which is something that is actually, those of you who work, it's a very complex question, is because we're moving from, and this has been true across administrations. In other words, like, value-based care is a term that's been around for decades, honestly. I mean, 20 plus years from just from my own experience. So in many ways, that's a term that could mean anything to anyone. But I think if you look at how we're building out the parts of it underneath, then you'll see kind of where we're going in terms of putting more meat on the bones of that phrase. So that, and outcomes are definitely part of that, and a crucial part of it, but it's, I think, to go even beyond the notion that we're looking at outcomes, but to see how we're going to be measuring them, how we're going to be looking at them, and kind of unfocusing on some of the process issues. And that line, you have to look at whether we've got redundant measures for reporting, where I think a lot of that has happened over time. So we're looking at kind of trying to deburden most broadly where we've got measures of performance that either are, again, duplicative, that have kind of topped out, where we've got quality measures that are sort of broadly, we're sort of paying for something that has 100% compliance, so that we're essentially doing a check-the-box exercise, which we really don't need to be doing. It wastes everybody's time on it. So we're looking at a lot of those to kind of move away from the large number of measures that have been in place over time to measure outcomes quality-wise, and figure out from a price transparency point of view what we're paying for and how we're going to determine that.
Well, thank you. I think that we promised to let you go. Thank you very much for the terrific questions. And Deputy Secretary Hargan, it's been terrific. Thank you for joining us.
Appreciate it. Thank you.